Hi, everyone, and welcome to another edition of Collateral Nation. This morning, we're a little bit casual. We have Kevin eating his morning biscuits, drinking tea, and I have my morning coffee that's fresh ground. And I'm with my dad, Kevin, in Bend, Oregon. This would be a dream for you. The hiking trails are extraordinary. You have so many different places. I think that here in Bend, Oregon, you could literally spend a year just doing a brand new trail every single day and never hit the same trail twice. And one of my favorites was, I think it's called Smith Rock. And it's the most incredible rock formation. And people were scaling one side and hiking the other to the summit. It's just a wonderful place to be if you love the outdoors. And for people who have peripheral artery disease, that poor circulation in the legs, there are a lot of rocks everywhere that you can walk a little bit, sit on a rock, walk a little bit, sit on a rock. It's the perfect, location. If you're dealing with that claudication that hits you every once in a while. But of course, right, Kevin, you got to push through some of that claudication. You can't just, rest every single time you get that claudication. You got to push through. It's your body telling you you need to grow new natural bypasses. So
Can I
you
make
got to push through.
a comment on that, Tim?
Yes.
Okay, when you're facing claudication in your calves, calf pain due
Yep.
to lack of blood supply, there are two ways to train. One I see is intensity training, the other endurance training, which is what I've been doing forever in Ironman, which is largely endurance. Anyway, if you keep going until your calf locks up, then you stop and sit down. That's how people generally start doing this. For me,
Yeah.
it used to be I could run 250 yards, then I have to stop and let blood in my calf, which would hurt a lot, but that's okay. Pain is part of the deal, and that's what we're going to discuss today.
Yep.
Anyway, that's what I call intensity training. A better way to approach it, which is a lot harder to learn, is endurance training. And the metaphor I use is the lactate threshold test that was used by my coach to train me for Ironman races. Oh, by the way, an Ironman is a 2.4-mile swim, 112-mile bike, and a marathon all in one day. Fastest I ever did was 67. I did it in 13:34, but it's a long day. Anyway, for endurance training, you don't want to lock your calf up. You want to keep going. That's the art of it. The lactate threshold test measures how much lactate you have in your blood coming out of the muscles that are active. And once the lactate starts to climb because your liver is struggling to convert lactate to glucose, you've got to back off. So you've got to find that point. And you get, with a lot of training, you get to know where that is. The lactate threshold test tells you the kind of wattage you can put out to be on the safe side. But for PAD, we don't have any lactate threshold test. All we have is pain, the pain in our calves or in our feet or a slight numbness of our feet. And my belief is we can substitute that for lactate by learning what feels right. So I've got a video on YouTube of doing that with the incline on the treadmill, where I show how I was taking it right to the edge and get to a point where I can keep going. And that was walking, of course, I think. And so you want to take it right to the edge of that threshold before the pain starts to become intense. And you don't push your way through. I mean, if the muscle's really hurting, you stop.
Right.
You can
It's to
sit
get to
down.
the point where it's intense. It's not, oh, I feel something, I'm going to stop. It's waiting till it's intense, but it's that balance, right? You don't want it to get to a point ever, actually, to
No,
when
no,
it locks
no,
up,
no,
because then
Tim,
you're risk
Tim.
for falling.
For endurance, you don't get to where the pain is intense. You get to
You
where
don't get to it. Okay, just
you get
making
to where
sure.
you get so you sense it coming on. You just can
Okay.
feel it coming on. You back off one click from that, and you can keep going, walking for 1 hour, never stop. If it feels at all easy, and this was a trick my coach also taught me, if you're feeling comfortable, you're not going hard enough. It means you need to click it up a little bit. So you start to feel where you can keep going for a long time. Because the goal, really, with PAD is to be able to walk around, do our stuff, walk up hills, walk to the store, do our walks, runs if you can, all day. It's not a 100-yard dash. It's a marathon that lasts all day. So it's really important to distinguish between those two. If you have intense pain, you should not push through it. You should stop and let the muscle refill. If not, then you're forcing a muscle to work that is lacking in its oxygen and other supplies. And that is a common mistake, I think.
Sorry, I had it on mute for a second.
Okay, that's fine.
Okay,
Yes,
that definitely makes sense. So, um, but it's still in a sense the same idea. It's not, okay, well, you end up starting to feel the pain and then you're just going to go and sit down. And that's the mistake that people make. What you're saying, correct me if I'm wrong, is so you have the one where the type 1 where you walk to the point where you're at a level 7 or 8 pain, and then that's the point that you can rest. Then you have the other school of thought, the second way that you can do it, which is where you end up walking to the point where you feel something and you just dial it back, you say, in your words, 1 click, but to keep walking as
correct.
much as you can in
That's
a
right.
way that you feel something, but it's not getting to a point to where it's so intense that you're going to have to stop. So two different ways that you can go about training.
Yes, it's intensity versus endurance. And when you're an endurance athlete, which I've been forever, you do intensity training to pick up your pace, but the intensity training isn't what you use when you're actually doing an endurance sport or endurance training. They're very, very different. And it does help to understand the mechanics of this, how the blood supply works. The more you understand about what's going on, the better you will do. So education is critical. Uh, so a lot of it has to do also with your tolerance to pain, and that is very different. I hasten
Yeah.
to add, I've never delivered a baby, so I haven't suffered that kind of pain, but I've done a lot of pain training, an enormous amount. And so when you train for pain, you can actually do a whole lot more. I know some people, they have the slightest thing, they'll sit down and give up. Most of the
Yeah.
people here aren't like that. I mean, we're not like that. But I did martial arts for 4 years. The first 2 years were kung fu. And I can honestly say that training was 80% training to handle pain. Some of the exercises were really intense, but not pain that will cause injury. And this is where we come to good pain versus bad pain. Good pain is the pain of training, exercising, improving your strength, for which you have to include recovery periods. That's really important to recover. It's also important to stretch, but we can talk about that another day. So the whole business of training yourself to deal with pain is really important. And you get to know it. It's like I wrote a short book which needs rewriting called Pain, Good Friend, Bad Master. It's a good friend because it prevents us from burning ourselves. It protects us from injuring ourselves. That's good pain.
Yeah.
You're using it appropriately. Bad pain is the pain of injury, where people will push through on a run and maybe a hip flexor's hurting or quad's hurting, and then they're crippled the next day because they went into the world of bad pain. And so knowing the
Yeah.
difference is really, really important.
So how do you tell the difference, or is it just individualized? It's different for everyone, and sometimes you have to trial by error.
It's experience, pure and simple, and every muscle's different. Every one of our muscles has a different balance or different ratio of fast and slow twitch fibers. And so each muscle has its own personality. For instance, I have a friend who has very sensitive hip flexors, the ones that help you lift your knees in running. And she's pulled her iliacus 2 or 3 times. And now she's learning how not to do that because I've been coaching her
Yeah.
for half Ironman races. Every
Wow.
muscle's different. Every muscle stretches differently too.
That's incredible. So for people with PAD, the pain is real. What do you think doctors don't understand about PAD pain for these patients? You're in our networks, and it's amazing to me that the pain that people are in, where doctors literally just brush it off and go home and say, walk, 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 and do nothing. What do you think that doctors don't understand about PAD pain?
Well, in this case, there are two kinds of doctors. There are doctors with PAD who understand it, and people without PAD who haven't got a clue. They have no idea. Unless they've been through a really painful process in their life, even knowing about emotional pain, and they might have gone through divorce or loss of a friend, it doesn't help you deal with this physical pain, which is extremely different, but it does come with emotional pain overtones due to loss of function. So emotional pain is also an important aspect of this training. That's why I always say when you start your training, my P.A.D. training book I'm writing is nearly done. The first thing I say you have to do, you have to grieve the pain of loss. You've lost the ability you used to have, and you have to grieve it and move on. So that's critical. Most doctors, I must admit, I don't want to beat on doctors. They have too many patients and too many diseases and too much pressure from the HMOs. I mean, really, to be honest, we are the best people to help with this. The doctors need to understand that peer experts can be extremely useful. Because of my medical training, I get an athletic and body movement training. I tend to fall in that group. I'd like to see some degree of training for peer experts where we can take this load off of the physicians, because how can a physician spend their time telling us how to train? They can't. That's the job of a body movement expert, yoga instructor, an athletic coach. The biggest problem with that is most of that work isn't covered by insurance. I mean, when I
Nope.
had a good job, I used to go to massage every week. I used to go to Feldenkrais training. I had a coach for my Ironman training at $250 a month. Now I can't afford that. I'm on a limited income. I'm 82 years old, living on Social Security and savings. And so I can't afford those things anymore. And this is why my website is called Inspirational Self-Help Books. I want to help people who can't access these resources. And so they need to learn how to help themselves. And understanding and facing pain is critical. Another trick with pain I learned from a, a program on NPR where a woman in Iraq, when things were pretty bad before we went in there, I guess, but I won't get into the politics of that. She talked about how she never knew when she was going to be taken in for torture. And so she would train herself to deal with the pain using cigarettes and putting them on her arm. So she had all these
Oh,
cigarettes,
wow.
but she was training herself to be ready. And she told me a really important trick. When you have physical pain in your body, your mind will want to run away from it. That makes it worse. You need to look at it, look at the pain. It can be your friend or it can be telling you back off, but you've got to look at it and not run away. I used this once in the dental office where I was having implants and crowns in all my upper teeth, and he had to put that horrible astringent string around my every one of my teeth at the top. It hurt a lot. It wasn't appropriate to anesthetize my whole head. I had to put up with it. So I used this lady's trick. And while he was putting this string in my gums, I looked at the pain rather than running away from it. And I'll be damned, it really helped a lot. It actually helped a lot. This lady taught me something really valuable. Well, she impressed the hell out of me, by the way. So pain is complex. My newsletter this week is about pain. I talk about various kinds of pain: psychological pain, nociceptive pain, idiopathic pain, regular old pain, you know what it is. Um, and there's also the case of a person who's a pain in the ass, but that's a whole other story. I try
How
to
did I
avoid.
know that was coming, Kevin?
Yeah, I'm sorry, I couldn't help it. Anyway,
I
yeah, pain for PAD patients and facing the pain. You won't do the training if you don't face the pain. It doesn't have to be excruciating. It just has to be a pain in the butt, kind of like irritating uh, to the point of, well, can I stand this? And then you find you can stand it more and more, and then you start growing collaterals. My right foot is almost entirely supplied by collaterals. There's no dorsal pedal pulse. My right popliteal artery, which is a major supply line for my right foot, is 100% blocked. Yet I'm still out there doing races. I'm at the back of the pack, but I'm there. So, and this is all because of growing collaterals through exercise. So face the pain, learn about the pain, see the pain as your friend, but don't abuse it by taking on bad pain. So that's my sermon for today.
I love it. I think I'd like to go a little deeper into, facing that pain, especially what that means for people with peripheral artery disease. Can you take them outside on their walk and walk them through what it means or what it looks like to face the pain when you're out walking and you end up with claudication while you're walking?
Well, it's actually terribly frustrating. It really is. It's as much a mental issue as a physical one. Here you are enjoying a nice walk on a sunny day with friends, and then suddenly you've got to stop. Or you're walking the dog and you've got to stop because your calf is locking up. And so you have to stop. And then you have to go through the pain of the muscle refill, which actually hurts quite a bit. And the further you push it, the
Yeah.
more the refill hurts. And so here we have pain again, even when we're not moving. I mean, think about that. So underlying that is frustration. And if you become angry, that will not help. You have to be patient with your muscles. And so, with a bit of practice and changing your cadence, how fast you move your steps, and the length of your steps, you can get to a point pretty quickly. I can now, I mean, I've been working on this for over 10 years. Um, I can get now, I'm at a point I can walk 10 miles and I don't claudicate. I don't necessarily go very fast and I have to slow down slightly on hills. And I can do 10 miles easily without any claudication, any calf locking up on my numb feet business. If I run, it's another story. That is much harder. I'm working on that. And once I master that, and I'm finding techniques, one technique is to change the load on your muscles. So now I'm experimenting on a treadmill with combining walking with a long stride and a very short stride run, which is a little tiny steps, right? Long strides, little tiny steps. And I'm trying to optimize the amount of time, minute of this and a minute of that, right? And so here I'm using certain muscles, and here I'm using different muscles in my hips and my quads, whatever. And I'm finding if I do that, the other day I went for a whole hour running half the time, walking half the time. That's pretty good progress. And the logic behind it is shifting the load from one muscle group to another. So while one muscle group is resting, the other muscle group is working. It's like being on a chain gang where you're having, there's two groups and they're on shifts. One shift is working while the other group's resting. And the ones that are rested now are replaced from the ones who are tired. I mean, this reminds me when I worked for Appleby Frothingham Steelworks as a student years ago when I was a vet student. In order to earn money in the summer, I got this job in Scunthorpe, Appleby Frothingham Steelworks, and they needed people to work cleaning a blast furnace. So they got, I don't know, 10 or 15 of us, and they set us up into three teams. They put us into equipment to protect us from the heat. This is a blast furnace cooling down. We're talking serious heat that can kill you. And we could go in there with all this protective gear and we'd scraping off the clinker on the inside of the blast furnace. I mean, it wasn't, we had face masks and goggles and all that stuff. You could,
Gosh.
you could stand it for 8 minutes. After that, you started to overheat and you had to get the hell out of there. And we'd go in shifts. So
Yeah.
three groups. So we'd rest for 16 minutes, do our 8 minutes, then go rest for 16 minutes. And that's how they clean the blast furnace. And this is how I'm trying to use my muscle groups in my legs, like that blast furnace, where I use these muscle groups over here mainly for a minute. Then I use those other, so these big, stridey steps for 1 minute. And then I do these little tiny low impact running steps for a minute and back and forth. And you can kind of see how I'm using different muscles in my hands to do that. I mean, these are like combined my digits here, so I can feel it using my shoulders. You have to take that thinking and apply it to your walking, and it works.
We had someone who used to be in the group and she runs a different group now. Her name is Monique. And she always talked about how she would do the treadmill. The moment she would start claudicating, she ended up getting off the treadmill and going on her stationary bike. And then when she started feeling relief and the capillary refill and she started getting the blood back into her feet, she would go back on the treadmill and then it would be recycle, repeat. What do you think about that? Is that a little bit of what you're saying? I mean, if you're out there walking, you can do the different types of walking, but if you're at home and you do have a foot bicycle and a treadmill or a stationary bike, that might be an option for you to continue the workout. But by the same token, you're working by working different muscles. You're not necessarily just stopping, because if you want to get a cardiovascular workout as well, you need to keep moving. You can't just keep stopping, because 3 in 5 people who suffer a heart attack have PAD. And so you got to get your heart pumping just as much as your legs.
Okay, that is an excellent strategy for cross training, acute cross training. I was thinking next week to use cross training as the next subject to discuss, because all this
That's
stuff is
great.
about feet, but there's a whole lot more about your whole body. I mean, that is actually an excellent strategy if you have a treadmill next to a trainer bike. I mean, I used to have a trainer bike, but I don't now. I got rid of it when I moved into my garden shed, and now I mean, I gave it away. But that is an excellent strategy where you're combining cross training with a gym workout. So yeah, I like that. Cross training is key. You mentioned cardiovascular. We'll cover that in another. We'll cover that in another session, because when you're out walking with PAD, you're going to have one hell of a job to get your cardiovascular training. I get my cardiovascular training in the pool. I go in the pool and I hammer away. I get no claudication. Your legs are only involved really minimally for propulsion, and to a great deal for maintaining a high position in the water. You need to be very high in the water. So that's where I get my cardio. You've got the bike is a great place for cardio. I also do a lot of cycling, of course. And but on a bike, to get good cardio on a bike is harder than in the pool. If you hammer a mile in the pool, you get cardio. You hammer a mile on a bike, you're kind of warming up. So it's a matter of how much time you have. And there are many, many ways to do this. You can have a good workout in the gym. You can do weight training in the gym. I mean, I have a 1.5 hour weight training routine that I use when I'm really fit. And I tell you, I superset every exercise, you know, like biceps to triceps, biceps, triceps, you know, do a set of these and a set of those. And I go through the whole routine for an hour and a half nonstop. I come out of there completely and utterly exhausted and my heart is hammering. So there's lots of different ways to get cardio, but you do need it if you want to grow collaterals in your heart, which you can. I don't know. Does that answer the question?
Yeah, that does. It just means it's great to have a variety, and you do need to make sure that if you aren't getting the cardio workout when you're just doing your basic walking and your exercise for just the legs, you do need to consider another option to make sure that your heart's getting the same workout. Because if you have PAD, you do have CAD, and you can. I love that you say that you can grow those collateral vessels around those blocked coronary muscles, around blocked coronary arteries as well. And that's really important to know for a lot of people out there. But it's still, and I think the biggest problem when it comes to PAD and getting that cardiovascular workout, it's still, you know, pushing through the pain. And you brought up something I think that is really important, because we've seen quite a few questions about this recently, where someone will say, I don't understand why the pain gets worse when I stop walking for a little bit. And you brought up a good point, that if you're walking to a point, if you're, it sounds like these people are walking to intensity, right? They're walking to the point where literally their leg is going to lock, and then they end up resting. And for those, and then they end up with the pain getting worse for a certain amount of time. It's called reperfusion pain,
Correct.
where it's the capillary refill. Would you mind giving us the lowdown on all of that?
Oh my gosh, the physiology of capillary refill. It hurts like crap. It really does hurt. I remember, oh my God, I had to go in and have my I got a abdominal aortic aneurysm stent graft, and the left arm of the stent graft completely occluded. It was repaired with another stent inserted, and it kinked. It caused turbulence. Well, it's not really turbulence, it's complex flow, but let's not get into Reynolds numbers and fluid mechanics. Anyway, and so it completely clotted shut. So my left femoral, my left main femoral artery was 100% blocked. I couldn't lift my leg, but it looked healthy enough. But they had to clear it, so they went in with a cannula. They broke up the clot, and when the blood flow came back into my feet, which was getting very little flow, the pain in my toes, it was enough. It was one of the most intense pains I've ever had in my life. And so when you walk to claudication and then you stop and rest, you're getting that very same pain, but in a minor form compared to what I had when I had a pretty well Percocet to deal with it, to keep still. Anyway, yeah, reperfusion pain is very, very painful. The physiology of it, I don't know. I'd have to go look it up. So I'm going to do that. That's what I like about these sessions. I learn things here. It's really good. I had a question came in, I think last week. I think the man's name was Stuart, and he
Yep,
contacted me
Stuart.
privately, and he said, "Well, how do I distinguish between, you know, claudication pain and maybe other pains I'm having in that same muscle?" And my answer to that is experience. That's all I can say, because all these pains feel slightly differently, but you have to become like a conductor of the orchestra. You've got to be able to tell the oboes from the strings. It's that kind of a deal.
And because
Experience.
there's so many different reasons why you could be claudicating. I mean, some of it is, and maybe a lot of it, especially when it comes to PAD, it is that poor circulation, right? And it is that claudication, um, pain due to PAD and poor circulation. But there are also issues where you might not be hydrating, you might not be getting enough potassium or magnesium, and that happens to all of us. And you need to understand the difference between whether it is the PAD pain from the poor circulation, or whether it's a claudication, whether it's a leg cramp from lack of hydration, lack of the minerals and elements that you need to feed your muscles.
Yeah, that's exactly right. I mean, I'm very, very fortunate in this respect, in that, well, I have medical training as a veterinarian, but I have athletic training as an endurance athlete, but I also did martial arts and a bunch of other sports. And I understand the physiology and biochemistry, and the bits I don't know, I go look them up. It's easy enough for me to do that. But I've also done body movement training. But then we may have someone coming in here and they're just starting to have the pains of PAD, but they've never had any of this athletic or medical training. It's our job to help them learn how to deal with it. And our biggest problem is communicating the information, simply because we have medical training, they don't. In fact, I discussed that with Doug. I think it was the day before yesterday on the phone.
Our
We had,
friend Douglas.
yeah, and he asked me about that. How do I get this across? And I think that is the biggest problem we have, communicating these ideas. And the best way to communicate with people is really example. They watch what you do. That's one way. And another way is using the right metaphors. If you have a metaphor, and he was thinking about, pouring water into a jug that's leaking and getting it at the right speed so it doesn't pour over the top. And that's exactly the kind of thing we need to seek metaphors people can understand. It's because if you have no knowledge of anatomy, physiology, biochemistry, which is because you've been a lawyer or you've been in a different world that we also need, it doesn't mean it's a negative about you. It just means you've been doing something else that I need. I mean, I don't want my airline pilot spending his whole life studying anatomy. I want him to understand the skies and how the GPS system works. So yeah, it's a pretty interesting problem. So I guess metaphor is the way to go. Josh had a comment, but I didn't get a chance to read it.
Yeah, it just came in. Thank you so much to our producer, Josh, for always being here for us. We absolutely love him, and he's over there on YouTube right now. So if you are listening, please feel free to comment on YouTube and let us know what you're thinking, what questions you have for Kevin. We have one coming in from Sue. She says, I have severe PAD. I keep getting blockages after the angioplasty. After my fifth procedure, I was able to walk for 45 minutes for 2 months, and then gradually over time, it's reduced. Now I can only walk for 3. And Kevin, if you don't mind, I'd like to just start with a couple of ideas for her, and then I'll leave it to you to also add in. But I'd like to address the importance of mitigating your risk factors. This is the number one reason why we see Patients end up with a revolving door of treatments is these plumbers are just kind of putting a band-aid on it. They clear the pipes, but they don't get to the source of the problem. And there are a lot of different reasons why you may keep clotting. Number one, it could be the skill set of the doctor. We've seen that where, bless their hearts, they're trying really hard. They go in there with their wires and balloons and they cause a lot of trauma. They're really forceful. They use a conquistador balloon and just blast the heck out of it to dilate the vessel and push that plaque aside. And that creates a very quick healing response in the vessel. Those are probably fewer and far between. The one we see more often than not is simply the fact that they have not mitigated the risk factors. The doctors say, oh, you're blocked up. We're going to go and unblock it and maybe put you on some Plavix, an antiplatelet, which is just a little bit stronger than aspirin for just a little bit of time and send you off with a statin and that blood thinner. But they really need to stop. And this is where advocacy, patient advocacy, you advocating for yourself, self-advocacy comes in, where you need to stop for a second and you need to say, hey, doctor, let's talk about the type of plaque that's in my arteries. Is it rock hard calcium? If it's rock hard calcium, you have to say, okay, what's damaging my arteries? Is it an MTHFR mutation? That's where you're not turning food into fuel and you end up where your B vitamins aren't absorbing and you have this enzyme that just goes through the roof. It's not being broken down. It's called homocysteine and it's like nails on your artery walls. It's what my dad has. It's actually what I have. And when you have that damage to the artery walls, that's going to call in the fats, the cholesterol, and everything to start, building up there to patch it up. Or the smaller little pieces of cholesterol can eke into the damaged areas and push that wall out. So there's number one. Number two, we also see people who have clotting issues, hereditary clotting issues, where they've never been to a hematologist and they've never gotten the advanced testing for factor V Leiden, factor 11, protein S, all of these different hereditary clotting issues that could also be causing it. If it is clotting, it could be coming from an aortic aneurysm. It could be coming from valvular issues in your heart. It could be coming from AFib. I've had two cases, severe cases, where the clotting issues actually came from undiagnosed lung cancer that we ended up having them get the test because they were still smoking and they ended up having lung cancer. And that was leading to the clotting issues. So you really have to sit down with your doctor and say, come on, doc, we got to stop this revolving door. We have to figure out what is actually the source of these blockages. And I'm off my soapbox, Kevin.
Very good. That was a good soapbox. The reminds me of a quote ascribed to Einstein, who said, "If I have 1 hour to solve a problem, I spend 55 minutes understanding and learning about the problem, and 5 minutes attempting to come up with solutions." So basically, you do need to know, if you can, the cause of the ischemia. You need to know that. One of the commonest, I guess, is atherosclerosis or arteriosclerosis. There are many potential causes. You can have hypercoagulative, platelet function, whatever. Anyway, so that is really the long-term problem. I will not say anything about statins. I don't recommend statins to anybody. They are muscle poisons. They cause rhabdomyolysis, and that's the last damn thing you need in a muscle that's struggling. Physicians disagree with me on that, but I'm a veterinarian, so I'm obliged to disagree with them. Other than that, yeah, you need to know that, but your acute problem is plumbing. It's a plumbing problem. And if it depends where they put this a stent or done angioplasty. I asked my surgeon in 2015 when they ran the ABI test and P.A.D was actually confirmed. I said, can you do an angioplasty or put in a stent? He said, Kevin, I strongly recommend against that. This is Mark Farber, an excellent EVAR surgeon at UNC. He said it risks losing your leg. So I didn't do that. He recommended exercise. I think he underestimated the amount of exercise you need, but that was my job. And so the best protection against all this stuff is building collaterals. And the effectiveness of building collaterals is really, really surprising. I surprise myself sometimes. I mean, I walk
Yeah.
around with normal looking feet and legs, normal toes, normal O2 SATs levels, and 100% blocked popliteal artery, and a bunch of other vessels blocking, and it's happening on the other side. And here I am still keeping going. And that is not attributable to drugs. It might be slightly due to diet, but not much. My problem is genetic hypertriglyceridemia, which I fixed with exercise, but the problem is a lot of exercise. Ironman fixed it and brought my blood lipids to normal. But exercise allows you to build ways to get blood to your toes through the back door. It's amazing how many collaterals and how effective they can be. So I say, go to your doctor. If they recommend to put in a stent or angioplasty below your knee, you might want to research that because people have lost their legs doing that. But building,
Yeah, I do want to add on there, Kevin, when it comes to below the knee vessels, are there are fewer options. Um, there are some doctors that will place a coronary stent below. We do have two new below knee stents that are bioabsorbable, one from Abbott known as an Esprit. But then we also have a brand new technology called Spur from Reflow Medical that's a retractable stent, because the whole key is, as much as you can and as much as doctors can, the more advanced doctors know it's better to leave nothing behind. And that's why I always tell people, and it's exactly what you're saying, is it's a red flag if the doctor says to you, I am going to go in and I am going to place a stent, and that's going to solve your problem. Because the only time they may ever say that is if the blockage is in your iliac arteries, in your groin, in your aorta, and in your heart. Those ones you're pretty much guaranteed the stents. But when it comes to your general legs, a more advanced doctor will never tell you that they're guaranteed going to place the stent, because with a stent it's not a matter of if it's going to reblock, it's just a matter of when, for the most part. And they're still waiting for some long-term data on the bioabsorbable stents. I know the 5-year data looks pretty good on those, but you don't want to depend on these procedures. The only reason to have a procedure is to bring you enough pain relief to get you walking, get you sleeping is probably the more accurate, and where more doctors are. If you have pain that's waking you up at night, that's where they're guaranteed they're going to need to do a procedure, because that's advanced stage P.A.D known as critical limb ischemia or critical limb threatening ischemia. Um, or if you have a wound on your foot that won't heal, then you do need a procedure. But as Kevin's been talking about, you want to delay a procedure. If you have just intermittent claudication, meaning when you walk, you claudicate, or you get a leg cramp, when you stop, you feel better, or if it's lifestyle limiting to where it's starting to hinder your ability to go shopping, do your job, things like that, you still want to start with a walking program first to see if you can actually get enough improvement. Because once you start the revolving door of procedures, it's just going to keep going and going and going. So the only reason to have these procedures: heal a wound, get some sleep at night, and make you walk further and faster so that you can grow those collateral vessels, those natural bypasses. So when they do block again, and they will, you're going to have enough collateral vessels, as Kevin has, so you won't need them to go back in and unblock that stent or that area that they once treated.
yeah, and if you have plenty of collaterals, the danger of any kind of surgery is they may cut your collaterals. And I think that's happened to someone I've been talking to. That seems to explain their symptoms. There's somebody came on, Josh said, who said they had an 8 out of 10 pain. How can they walk?
Yeah, and that was Sue. Sue is the one that messaged a few minutes ago that she keeps reblocking. So her number one is she's going to talk with her doctor about why she might be experiencing that pain, and why she keeps reblocking. But how do she's got to try and figure out how to slow down also this revolving door, maybe with a walking regimen. And how do you, if your pain is 8 out of 10, how do you continue to walk? How do you create a regiment that can get you through to where you're starting to build those collateral vessels?
I think you have to do other things. I mean, I've put exercises on YouTube the P.A.D. 100 and stuff like that. That exercises your legs quite well. If you have access to a pool, you can do quite a bit of work in the pool that won't cause you to claudicate, but will contribute to the both growth of blood vessels. And so also you can walk in the pool where you're just touching the bottom, so there's not much weight on you, and you can go slightly shallower, so you're controlling the amount of load. You can use an exercise bike, and that will also help. You've got to find ways around this, and some of that is cross training. You have to be your own detective. I think at the end of the day, I can tell you do this and tell you do that. Excuse me, people tell me I look like a chimp when I do this. I'm just busy thinking. At the end of the day, you have to think like a P.A.D. detective and understand that what you have is a hydrodynamic problem. It's a problem of working out how the hell to keep blood getting all the way down to your toes. And the way to do that is to think and try and find different tricks. And a trick that works for me may not work for you. So I would try all sorts of cross training. That's Sue, right?
Mhm.
Yeah, I would try anything I can to see what works. If you go and look at my P.A.D. 100, when I do that exercise each morning, and I do it lying on my back, it really works everything all the way up to my hips. It's a pretty good workout. And if you get up to 100 of them, you're doing pretty well. You could try and get up to 1,000 and do that, and I'm sure that would grow some vessels in your legs. Whatever works, it's whatever the hell works. It's a battle, and we're all in the same battle. So if I could
And
come up with,
I love that you say, Kevin, you're always thinking, what can you do? Focus on what can you do. You know, you need to grieve what you can't do. You need to put that behind, and you need to focus and accept where you are today and start moving forward from where you are. It's just like with my dad when he had the hip surgery. Well, you know, before his hip started bothering him, he was going 4 miles, going up the hills, everything else. And now he has that as a goal, but he has to start where he is today and progress as his body allows him to progress and move forward. If you're focusing on what you can't do and the fact that you can't do those 4 miles today, you're never going to progress. Is that really what you're saying with in terms of the mindset that you need to have in order to start facing the pain and moving forward?
yeah, absolutely. You have to be an endurance athlete and a detective all in one. That's the deal. Keep up with the literature. Try and avoid surgery if you possibly can at all cost. I managed to remember I mentioned there was a guy on the elliptical who had a prosthesis on one leg, that he'd lost his one leg from the knee down, and he was working on a prosthesis. He was on the elliptical. I got to talk to him. He wouldn't let me take a photo or a video. I really wanted to, because here's this guy on the elliptical trainer, and he's got one leg he's lost from the knee down. He lost it as a result of surgery. Doug, you look really weird like that. Anyway,
We just had our friend Doug join our live studio audience, the
anyway,
chairman of our P.A.D. Warrior Task Force, and he has his safari hat on.
anyway, it turns out this guy, he's 88 years old, number one. He still has an active profession as a photographer of dance. And also said he lost his leg as a result of a surgery in his ankle, which caused him to catch MRSA, which was eating his leg up, and they couldn't stop it, so they had to cut his leg off. In fact, don't have surgery if you can ever avoid it. I needed to have one of my shoulders I dislocated, and the shoulder surgeon said to me, Kevin, you don't want to have surgery unless you have to. And by looking at your MRI, you can fix this with PT. So I did. That's a sign. The best surgeons are the ones that tell you not to have surgery. But they will tell you when you have surgery, you have no choice. I had no choice to have my EVAR surgery. I had to have a stent, or my aneurysm in my aorta was a 6.9. I mean, my aortic
Oh
wall.
my gosh, you never told me that. Are you serious? A
Yeah,
6.9.
yeah,
That's well above where they would say is safe.
well, I found it by chance. It's all in that video online. The Cook Medical sent a film crew down in 2011. Okay, in 2010, I worked out I had a problem. I was 10 miles into the run, and I started getting burning on my feet in the Lake Placid Ironman. I was 67 years old. You know, I was young. I feel I was really young. and that was one where I did my fastest Ironman. But a guy dropped me at mile 137, so I didn't get the world's counter slot, which was a bit of a bitch, but I didn't care. Anyway, I had this burning on the bottom of my feet, and the whole story is in a video online. It's called The Creation of Fit Old Dog. That's my brand. Anyway, I was lying in bed one day and I saw my abdomen was moving up and down with my pulse, which at that time was 38. I was in good shape. And that's what led to my diagnosing the aneurysm. I went to my physician. She listened to my abdomen and said she didn't think there was anything wrong and I probably had indigestion. And I'm like, what the fuck? Excuse me, I shouldn't use elitives or whatever you call them.
Hey,
Richard.
Josh, producer, where's the bleep? I'm just kidding. That's
Anyway,
only on radio or
I
television.
worked it out,
You're
and
good.
I had a stent installed, and that stent's kept me alive since 2010. In 2011, I made changes to my training to protect my stent. Once again, detective work. I realized that I would risk the stent dislocation by excessive hip flexion, so I stopped using the rowing machine. I would stand when I'm riding the bike on bumpy roads. I didn't want to shake it loose, which actually happened in 2013 in Worlds Half Ironman Championships, where I was in Vegas, where someone ran into the back of me and that dislocated it. But that's another whole story. Anyway, by modifying my behavior, I could continue doing Ironman. And so I did. And you can see me finishing the 2011 Ironman race with a AAA stent graft. So, but I'll tell you what, that was difficult, but P.A.D is worse. P.A.D is a real, P.A.D is terrible. It's a pain in the ass.
I'm going to say it. It's a real bitch. It
really
really is. I mean,
I was going to say that, but I thought it would be rude because it's kind of sexist.
well, you've already said other things, so
Oh yeah,
that's tape.
true. Sorry about that. Hi, Doug. You
Um,
look better now.
it's just, when it comes to P.A.D, it's not easy. And I think that doctors need to understand that there needs to be a little extra love and support and accountability for patients with P.A.D, because it's scary. You do have online, when you go onto Dr. Google and or should I say Dr. Yahoo or Dr. MSN or Dr. DuckDuckGo, whatever search engine you're using, like Dr. DuckDuckGo. That's has a ring to it.
I use DuckDuckGo.
Yep. And so when you need that accountability, because when you go on there and you have this one chain of vascular centers, I think it's USA Vascular or something, and they have optimized search for their organization and their blogs. The number one thing that comes up every single time someone searches for P.A.D is they're going to be dead in 5 years. And it's just not true. That might have been true way back when, but it is not. Even patients that have CLI, the newer, more advanced techniques, all of this type of information, this is really helping people to get to a point where they can pull themselves out of CLI, get their wounds healed, and get that blood flow they need to get back on their feet to start growing their collaterals. The thing is, Kevin, is that I think, to me, when I see people like you and I see people like Douglas and people like our friend Mike that typically joins us from Canada, who's originally from the UK, in order to get a handle on P.A.D, it's a full-time job. You really need to put 100% of your focus in the early stages to be able to get to a point where you can actually walk to live and live to walk.
There's a book I put on your P.A.D support site written by Stephen Pressfield. It's called Turning Pro, and it's worth reading. It's a very entertaining book, but it's mainly talking about the arts. I mean, I'm a writer, so I have to have discipline, the discipline of a professional writer, which means putting my butt on the seat and writing. But that book is very good for encouraging people to take a professional approach to fighting P.A.D, because P.A.D is a professional. P.A.D works 24/7 to get rid of your legs and destroy your life. So you have to fight back with a similar attitude. You have to be a professional P.A.D fighter. You might not have
Yep.
the education needed in certain areas, no problem. Which brings me to the issue of, yeah, Gates of Fire is an amazing book, but also Killing Rommel is better, Josh. And so that's another story. Um, and so I think it's really important to do that. It's to understand that you need to be a professional fighter. And when it comes to peer experts, on my website, I wrote a whole article in there. I think there's even a picture of you in that article, Kim, about the nature of peer experts. As a peer expert, you do need some training, but you don't want the medical profession stepping in and telling us what to say and what not to say, and then, sending us to their damn drugs, which are they're also poisons. And I say this having worked for and in the pharmaceutical industry for 17 years. The people on the bench are really trying to cure stuff, and they're good people, 99%. But once you get to the commercial aspects of pharmaceuticals, you better watch out what you're buying. You better understand what it is, because now you have commerce and sales and marketing, and those are different worlds because they have to make a profit. If they don't make a profit, they go bankrupt. So they're
Well, a lot of those are just band-aids, and it's literally an excuse for you to not take your health into your own hands. I had a situation, Kevin, that's exactly kind of what you're saying. Like it's just this. That's what people in medical school, they go to medical school to learn how to prescribe a lot of these medications. They're not taught to really get to the source. And so, for example, I ended up having you. I'd sent you some of my blood work, and it all painted a picture of I was deficient in vitamin B, vitamin B vitamins, B vitamins. And so what I did was I literally doubled down, tripled down on my B vitamins. And then I started feeling nauseated. I didn't know you could overdose really on vitamin B. And I
Yeah,
started feeling
never,
nauseated every day.
never eat polar bear liver. Do you know about that?
No, uh-uh.
Well, polar bear liver has killed a number of explorers because they store vitamin A in their liver to the point of it being toxic for humans. And if you eat polar bear liver, it can kill you. You can have too much of any vitamin because they're just
Yep.
chemicals. And most of them are coenzymes that are important in biochemistry. So, yeah, it's true.
I
So,
didn't realize it.
actually, your blood
But
work was pretty interesting, to be honest. I thought initially I was concerned about a space occupying leukemia. I was concerned about, but your hematocrit and your blood, your levels were fine, except you had a low corpuscular hemoglobin level, and your mean
yep,
corpuscular volume was slightly up. And that, it turned out, was a classic symptom of the genetic situation you were talking about.
yep. And I'm going to use it, my motherfucker gene. Sorry, I'm THFR.
Oh, it's
It's
a good way
just
to
what it
remember.
is.
It's a good way to remember it.
I mean, and a doctor actually said that he was tired of me calling it the MTHFR. But all it is you just, I mean, literally, it's just one of those genetic snippets that got flipped on, and it makes it so I'm not absorbing my B vitamins properly. So we talked about that homocysteine. The enzyme goes up, starts scratching your arteries. But the key is you need to balance out and get the right methylated B vitamins. And for me, I had gone a few days. And so that explains the blood work. But then I ended up doing too much. I got blood work showing at that point, my B vitamins were through the roof. My folate was through the roof, high B, high folate. And it was no wonder I was really nauseated. But the first thing the doctor wants to do is give me a prescription for Zofran or something for nausea. And I'm like, no, 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 no. The nausea is a signal that something's going on. And thanks to our nurse practitioner, Deidre, who is on every Wednesday, she said, Kim, how much B are you taking, the methylated B? She says, you need to not supplement yourself. And it was a good lesson to make sure that you should get a functional medicine practitioner to be able to find those proper doses of the vitamins for you. But once I ended up taking a break from the B vitamins for a couple of days, I felt a lot better. Now I'm back to proper dosing of them and I feel great. So it's just a matter of knowing your body again, right? Knowing your body.
Yeah, knowing your body and knowing your nutrition. There's a question came in about
Yes,
occlusion
Nancy.
of the iliac, the common iliac artery, I guess. Right now, I'm starting to struggle with blockages up in my hips. I think you can probably grow collaterals around any vessels if you can find a way to do it. Around your aorta might be challenging. You mean you need to grow another aorta? I'm not up to that yet. But yeah, I think you can. I'm having to deal with that in my hips. And that's why I do the treadmill incline training, which is actually helping a lot with that. And one, I
They
want
say
to,
that you're less, those are really big vessels. Your aorta and your iliacs are really big vessels. And if those are blocked, a lot of times it's better to get if you have that lifestyle limiting, and you always should try regimented walking for 3 months, but then if it's not getting better at that point, you really should end up, because they supposedly, this is what I've heard from doctors, vascular surgeons that have been on, you're less likely to build the collateral vessels around there. There are other vessels like the inferior mesenteric arteries that feed the gut. Our friend Douglas that's here, we always use him as an example. We love you, Douglas. But he ended up at his inferior mesenteric artery that first feeds the gut, then goes into the legs secondarily. His was literally feeding his entire legs. His had dilated to a point where it was literally feeding and keeping his legs alive. So your body does have miraculous ways in which it tries really hard, and it tries to meet you where you are. If you're putting in the work, it's trying to put in the work with you to grow some of those things. But for the iliac arteries, they say it's a really important conversation to have with your doctor. Try a regimented walking program, making sure you're mitigating your risk factors. And then if that's not working, to go ahead and if you do get some angioplasty done, or they have this newer device called Shockwave where they use audio waves. If it's actual calcium in there, they can crack the plaque, use a drug-coated balloon, and then they place a stent in there. And those are pretty durable for a long period of time if you are doing your part to walk, walk, walk.
yeah, I have my common iliac on the left side stented in order to repair that kink, and it's been working since 2017.
Yep.
So that's good. I just want to make a quick comment on taking a doctor's advice. It's quite an important little story. A while ago, I don't know how long ago, 25 years or something, I had pain in my ear, really severe pain in my ear. I assumed it was swimmer's ear, otitis externa. I go to a physician because I can't get antibiotics without their permission. He looks in my ear and he says, Kevin, there's nothing wrong with your ear. Are you grinding your teeth at night? And my life was extremely stressful at that time. And it turned out I probably was. He said, you have TMJ, temporomandibular joint pain. And he starts writing a prescription. And so, hi, Mike. Anyway, he starts writing a prescription. I said, what's the prescription for? And he says, for Valium and a strong anti-inflammatory to protect that joint. Valium will calm you down so you can carry on, and get on with your work. And I said, no, I'm not going to do that. I'm obviously under stress. I need to back off. I said, what I'm going to do is I'm going to take a week off of work. I'm going to meditate more, take more country walks, and do that. He insisted on handing a really nice doctor. I mean, a young man, really great guy, insisted on handing me these two prescriptions, one for Valium, which is addictive, and an anti-inflammatory, which is a potent chemical. And I said, I don't need them, but he insisted on giving them to me. So I went outside and I tore them up and threw them away. And then I put in my own training plan. I took a week off from work. I backed off. I chilled out. And within about 10 days, the pain in my jaw gone. And I didn't subject myself to chemical intervention. So you, at the end of the day, get to choose. I mean, maybe it would have got worse. Maybe I made the wrong decision. But in my opinion, in that case, I didn't. But before you just do what the doctor says, do a little bit of thinking before you just go down that road, because they might be wrong.
Yeah, it's always good to, again, it's self-advocacy, number one, but two, being a partner in your care. And there's so many different ways, and that's why I love this podcast that we're doing every week, is because we focus on what you can do. You can do on your own, not relying on just medications. It's what are the natural ways in which you can improve your cholesterol? You can improve. There's my dad behind me. We are, again, for those just joining us, we're in Bend, Oregon, enjoying the hiking trails and just the beauty up here. It's
I can't see
absolutely
your dad.
a dream.
I can't see your dad. You got that global P.A.D thing there instead.
I do. He kind of it got into my little blur, into my field here, and so you could see him leaning over.
Miss that. How you doing,
Um,
Mike? How's Mike
Hey,
doing?
Mike, we had Mike that's joining us in the last few minutes here. We should say hello to Mike. We should say hello to Douglas. And also, it would be really fantastic, Kevin, if you can do a recap of what we talked about when it comes to pain and dealing with pain and helping to acknowledge that PAD is very painful, and to make sure that people understand that they do need, how do they face the pain in order to move forward.
Well, basically, you have to be your own detective to study what's going on and understand why. That's number one. Number two, you have to learn the difference between good pain and bad pain, the pain of training and exercise, and the pain which could be causing injury. You have to understand there's two ways to train to fight PAD to grow collaterals. One is what I would call intensity, where you walk until you claudicate, you stop, you rest, you put up with the pain of refill. The other is endurance training, where you stay shy of that lactate threshold equivalent pain and you take it to the edge and you keep going that way so you don't lock up. And so you're pushing it to the very edge. And I recommend you look up lactate threshold training in order to understand that. And in place of lactate, you're using pain. You have to be very, very patient, and you have to understand it takes time. And the real trick is to overcome the mental challenges, because people get depressed and they give up.
Yeah.
One way around that is to continue exercise with cross training. I do that in the pool, where I can train my heart out without any form of claudication at all. On the bike, it's pretty well the same, except for a steep hill climb. So at the end of the day, you get all the information you can, but you take responsibility, and that will give you a good feeling of you're in charge of your life. You now are in charge. You're not at the mercy of the next doctor's appointment, even though you go. You listen to what they say, but you decide what to put in your mouth in terms of pills or whatever, or surgery. Take charge of your life, and it will make you feel a lot better. And what really helps me more than anything is hearing that I've helped someone else. That to me, at the end of the day, makes all this work satisfying. So that's a simple recap, Kim.
That's fantastic. And Douglas and Mike, how have you guys been doing? You join us every single week. You're here in the live studio audience. Douglas, we talked about you a little bit in the beginning, where I heard that you and Kevin had a great conversation this week about the different metaphors that you could use to help explain to someone how to maximize their collateral vessel growth. And so you had mentioned to Kevin about what did you say, filling a leaky water jug.
Wake up, Doug. Yeah, we were talking
There's
about
Douglas.
metaphors, the value of metaphors.
And I, I'm just going to go back to the beginning. I'm going to keep it very simple and plain. The mental health side is just as important, you were talking about. And you can read, you can write, you can look, Google, all that, but it's pretty easy for me. I stand up, I take one step. And it's once you practice that, you develop a routine. Then when some after a while, you're not going to want to sit on the couch. You're going to want to get up and do something. That's the whole point. So if I'm doing something and not sitting on the couch, my mental health is so much better, which affects my PAD and my CAD, because I'm active. I'm not sitting on the couch watching The Price is Right, which is just enough, you know? And
Come on down, start walking.
yeah, and so the depression does get you, and you can get down, but I have days where I'm down, but I'm still doing something.
Yeah.
I'm
And
still
this is a really good point that you're making, Douglas. And I even think this is a whole uh, show in and of itself is you move it or lose it. And the more you're sitting, because so you start out, you feel pain, so you sit, so you don't want to move. So you sit and then you sit. And then the next time you move, the pain is worse. And it's because the pain is getting worse because you're not moving and your body ends up stiffening. Can you talk just a little bit about that, Kevin? Because I think it's really important. We have patients that'll tell us, well, I'm now just laying in bed because it's now even more painful than ever to go ahead and get up and walk. And that becomes something that is also, um, as Douglas was saying, both physical and mental. It's also emotional, which brings us back to the beginning, full circle in the conversation of pain.
Basically, mathematically, that's a negative impact of a positive feedback loop. So there you have some pain, so you sit some more. The next time you get up, the pain is worse. So what you're doing is you're feeding your mind and your body into death, basically. I mean, you will eventually kill yourself by inactivity. So Doug's answer is exactly right. Do something, for God's sake, do something and get moving and do what you can. That it really, apart from all the intellectual stuff that I tend to put in because I'm a researcher, I always have been. At the end of the day, you have to do something. Understanding is good. My understanding has helped me develop the P.A.D 100 and different techniques. That helps. But if you don't get moving, none of that's going to help. Doug is exactly right.
There's two things. The two things when I think about that, Kevin, is every now and then my pain level is a 4, and it's not. And I've been dealing with this for 5 years now, so I've kind of come accustomed to that pain level and doing something. There are days my pain level's an 8 or a 9, and yes, it slows me down, but I'm still doing something. So every now and then I think I have become, ooh, I like the pain now. Bring it on. It's kind of crazy to think about that, but I'm still doing something. The second part about that is, you know what? When I lay down at night and my brain is with my brain and me only, I'd rather have that thought. You know what? I got up and walked to the end of the driveway today. I got up and I did this. I got up and I did that. I got up and I did this. Instead of laying in bed at night thinking, what a wasteful day. I stayed on the couch all day. Because if I do that day after day, well, then I develop that negative connotation. And that's how I'm going to get up the next morning. So it's so much easier to get to lay in bed at night and go, you know what? I had a rough day, but I got 15 pieces of wood done for my little place I'm building. I did something. I got up and I raked half a yard. I got up and I vacuumed the truck. I did something. And that's the whole point. And everybody's pain level, we know, we all know people whose pain level's a 5 and it just shuts them down. And that's crazy to think about how different all of us adjust and think about pain when we deal with it, isn't it?
Yeah, you have to have a reason to get up. There's a famous quote by that philosopher with the weird mustache who said, whose name escapes me right now because I'm elderly, I guess. He said, anyone who has a why can overcome anyhow. You have to have a reason. You have to have a reason. I do most of my writing in order to help people deal with the problem. That's a large reason I write, is because you want to do some good in the world, and it depends. For some people, it's being able to walk their dog. It doesn't matter what it is, as long as it gets you satisfaction and you have a life. Doug's right about that. And he does great woodwork, by the way.
Douglas does the most amazing woodwork.
And it started off with, so I'm doing a different project for the house and I'm learning how to do something different because 20 years ago I would just manhandle it physically. But today with my graph, I can't do that. So I'm having as much fun learning new ways of doing things and getting things done as when I just manhandle things. It's exciting to know that, yes, my graph will stop me from doing this. But you know what? I've learned how to work around that now. I've learned how to do something now and get the same job done It might take me 4 hours longer to do it, but it still gets done. So it's that part about getting up and still being excited about, yes, I'm having issues. My heart's been acting up a lot lately. It really has. But I'm still going. I'm not gonna you're not gonna if you find me on the couch dead watching The Price is Right, I'm over with. I'd
What's the
rather
price
you
is right?
find
What
me.
is that? Is that some TV show or something? What is
Yeah.
Oh,
that?
you've never seen it? It's a
You've never
longtime
seen The
TV
Price is
show.
Right?
Oh,
Yeah.
I haven't watched TV. I haven't watched TV in nearly 50 years. Seems like a
People
Well,
end up
total
wearing
waste.
costumes and going down and bidding on figuring out what the price is. They
Oh, God,
compete to see who can get the closest.
I'd rather read a book.
It was
Thanks.
it, it used to be massive in England as well, so it was a big show in
I like,
England, that was. Hi,
Yeah,
sorry,
yeah.
I'm just doing my shopping. I'll be with you in a second. I'm just bagging my shopping up. I won't be a sec.
I love
anyway,
that. He's out and about. He's with the shopping cart and he is out and about. That's fantastic, Mike. It's
what
good to
Yeah,
the
I've
see
walked
you,
there as
you
well.
moving.
show us all the healthy things you're fixing to get.
Yeah, do you notice
Let me
that
just
in
tell
his,
you.
he's not showing us his shopping cart because he doesn't want us to see it. But I know, oh, look at this. Okay, he's got the whole
Spring
grains
onion,
and he's got the
tomatoes,
tomatoes.
pepper, celery, cucumber, low-fat yogurts, Diet Coke,
Uh-oh.
Uh-oh.
fish, and some lettuce, some water, some rice crackers,
So
crispy
put
mini
the
rice
Diet
crackers.
Coke back and get some more water.
and get rid of the low fat yogurt. That's a whole nother story. Low fat is a big mistake, but we'll talk about nutrition another day. And what Doug mentioned is about body movement training. He's found new ways to move. Body movement
Yeah.
training is a critical part of keeping going with PAD. It's something I've studied for years. I mean, it really, really helped a lot learning how to move your body optimally. So yeah, but that low fat yogurt, oh man, don't eat that stuff, Mike.
Too late now. I've already paid for it. I'll eat these ones and I'll give it up on that one.
Yeah, I mean, the thing is, we get energy from only two sources, basically, carbohydrates and fats. And carbohydrates tend to be inflammatory in nature. If you cut out the fat, you're going to eat more carbs because you're not going to get your energy from anywhere else. You get almost no energy from proteins, and it generates a lot of nitrogen and gets peed out through the urea cycle. So you need to get the energy from somewhere. And so the real trick is balance, and that balance will depend on how fit you are and how much you use, oxidative phosphorylation versus glycolysis. It's just basic biochemistry. The low-fat thing caused people to eat more carbs, and it did more harm than good. And what were the carbs they ate? Fructose, high fructose corn syrup, which has been extremely damaging for Americans. And so, yeah, that's my soapbox, Kim.
And Kim, one more thing. That's what Kevin and I talked about yesterday is
Yeah.
everybody think about this. I'm 63. I've been walking for 61 years now, 62 years. I never thought about the proper way to use my body for better mechanics
Yeah.
than since I got PAD, like walking with the toes and the feet and the right shoulder going forward when the right leg's going back, the proper techniques and walking
Yeah.
to optimize my body for the best. We don't ever think of it. We've never thought about how we walk and how we
And
use
it's
that
so
to
true.
improve our condition.
Douglas, you bring up such a great point, and I love that it's because Kevin brought this up before, is how do we make use of what we have? Like, why do we have paddle? Maybe it's to teach others about the right way to walk. I mean, I'm actually now, Kevin, you're going to be really impressed. Like, I'm even learning so much from you. I'm learning from Douglas. I'm learning from all of you. I'm sitting there and I'm now, even when I'm sitting in the car on these long car rides in between the hikes, is I am actually curling my toes under. I'm clawing my toes. I'm, practicing. I'm picking up things with my toes to keep them moving. And I can feel those muscles moving clear up into my calf when I'm clawing with my toes. And it's incredible.
It's basic biomechanics is what it is.
But you use it or lose it, right? We used to use those toes when we were climbing trees, when and we were grounding and clawing at the ground to move our way forward. But now that we wear shoes, we don't really use our toes. And
So
we need to use our toes.
imagine from where we walked, say, 10 years ago, a mile. And today we learned how to walk properly. We walked that same mile, but 10 years ago we used 100% energy to get to that 1 mile. Today we learned to walk properly, and we learn now we're only using 50% to get to that 1 mile. So now we can do the 2 mile because we got better performance in our walking style and our walking habits to walk that extra step and build those collaterals and get past that and be able to walk a 5K or a 10K or run. I'm never going to run a marathon, but I can dream about
I
it.
don't
But
know, you may.
You
We're
may,
getting a lot of people.
you're only
Kevin,
62. What's a kid?
I was thinking, Kevin, as part of this, it would be interesting. We have quite a few people that are now inspired through watching you and and then others are adding and trying to, they want to participate in 5Ks. Maybe we can start something over the course of September, P.A.D Awareness Month, where we start on our first week and we start training for the 5K. So those who want to train with P.A.D for a 5K, we can actually each week, every Wednesday, we can have a different lesson that leads everybody through training. And by the end of September, those who are intermittent claudicants especially, we can get them to a point where maybe they can at least complete a 5K.
I've started doing 1 minute interval runs on the treadmill when I'm doing and I'm actually on an incline of 2.5 as well when I'm doing the run. So every 10-15 minutes, I'm just throwing in a minute of running time as well. And that's down to
Wow.
Kevin. I must admit, that's down to Kevin and his encouragement on doing things like that. And I just wanted to say to him, I love the fact that you're in Oregon. My sister-in-law used to live in Gresham. We used to
Okay.
go to Oregon.
It's
And we used to
gorgeous
go
up
up,
here.
we went up Mount Hood, and we went to a waterfall called Multnomah Falls. I
Okay.
don't know if you've ever heard of that, but that's in
Yeah.
Oregon, and that's a beautiful walk, a lovely waterfall as well. Just for your information. So, there's a
I
little
love it.
old
We're going to
woman
go
walking in front of
to
me.
Crater Lake. Oh, look at you walking. So Mike is actually showing us are you walking home from the grocery store, Mike?
Yeah, yeah. And there's a little old
Oh, wow.
lady in front of me with a walker, and she's nearly walking as fast as I am.
Yeah, you got to watch out for those little old ladies. They'll run you down.
Yeah.
But I love that you're adding a little bit of extra to your walking because that can add resistance training, right, Kevin? When he's
Yeah,
carrying his groceries now while he's walking.
that's another way that also, if you carry stuff, it offsets osteoporosis. That's a whole another story. That's a
Oh my
whole nother
The
goodness.
bags
story.
are heavy though.
What did you say, Mike?
I keep on having to swap hands with the bags though because they're quite heavy, and I've got my phone in one hand and the groceries in the other. So
Well, maybe
Well,
next week, maybe next week's session should be on body movement training. I've done 5 years of Feldenkrais, 2 years of Pilates, 2 years of yoga, 4 years of
Wow.
martial arts. I did Continuum for a year, gyrokinesis for a couple of years. So,
Oh my
and then
goodness.
swimming, all sorts of different sports. But all these things taught me different stuff. I mean, Pilates for core, Feldenkrais really for relating to your skeletal movements and integration.
Hmm.
Martial arts for efficiency of movement. Each one was different. Continuum, which was really good. All you need is a chair for lengthening your spine, improving your, the way you stand, your profile. Yeah, no, the way we move is really really quite important, and you can improve it all the time. In the pool, for instance, I'm always working on integrating the timing of my kick with the timing of my arm stroke. And you get that right, and it's so fluid and easy. And when it comes to running, if you run with your shoulders and you get good shoulder hip counter rotation, your spine will carry you along. It's absolutely true, because it acts like a mechanism in a clock. So you're using your spine as you move your shoulders one way and your hips the other. It twists your spine. So use that reflex much like a mechanism in a clock. And so you can learn all that from Jack Hagee's books. And also, I like the work of Danny Dreyer, so-called chi running. He's written one on chi walking. And that basically is a low impact approach that uses whole body. So there's some of you down there doing the P.A.D 100.
I love that. That is Douglas. Douglas is in our live studio audience, and he's sitting there and he's doing his P.A.D 100.
Yeah, he's spreading his toes very well too. That's important.
Good job, Douglas.
You need to flex your feet a little more. It needs to hurt a bit. So when you bring your foot down, you need to really flex it, like really flex it. And that engages those like 8-10 muscles in your feet.
Yeah.
But you're doing good. Yeah, that's better.
Nice job.
That's much better.
And so it just is a reminder that you can always join our live studio audience and just email us at info@padhelp.org. And you can get some live feedback from Kevin on the exercises that you are doing. That's why we're doing these sessions, so that we can give you live feedback, answer your questions live. Make sure you do go to inspirationalselfhelpbooks.com and you sign up for his newsletter. This week, we've been talking about managing the pain of PAD, the reality of pain of PAD. And he is going to have that in his newsletter that is going out this week. So you don't want to miss that. And you can also subscribe to his YouTube channel, youtube.com/the@fitold-dog. You can subscribe to our YouTube channel at youtube.com/the @ and then the way to my heart. But please, 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 please like this video to let us know that you really are learning something from us. We love the feedback, but it also helps to generate additional views on YouTube as well, because the more you like this video, the more people that YouTube will show it to, because you find it helpful. So it's likely that other people will too. Also subscribe to the channel to make sure you get notified of all of our great content that we have every single week, and opportunities such as this where you can talk to experts. But remember, get explicit consent from your own healthcare provider before taking any advice offered here. This is for educational, informational purposes only. Do not act on any of the information here. Do not start a workout regimen until you check with your doctor to find out what is right for you. And with that, thanks so much, everyone, for joining us. We really appreciate you. Next week, Kevin, are we talking body movement, or are we going to talk cross training?
Actually, I think cross training would be a better one to approach right now, because body movement is complex and people need to be a little further on. So yeah, cross training is the only way we're going to get cardiovascular.
Fantastic. Thanks so much, everyone, for joining us. We appreciate you. So we'll see you next week.
I wonder if Kevin, if Mike's going to let that lady beat her to the end of the block, or is he going to? Is he going to?
Good way to end it.
No, I just saw him push her off into the bushes.